We're going to go ahead and get started with our second part of the morning. We have our panelists here ready, and we want to continue the conversation that we had with our first panel of traditional healing policy and action. The second panel is traditional healing and Medicaid. And the discussion is going to center around an exciting announcement that was made in October that expands access to traditional healing services at the Indian Health Service, tribal and urban Indian organization facilities. The panel will be moderated by Eileen Sylvester, who will introduce our distinguished panelists. Eileen serves as the Executive Vice President of Executive Services at the South Central Foundation, where she currently oversees tribal relations and village initiatives for healthcare delivery to 55 rural villages, traditional healing, youth internship and elder programming, public relations and corporate communications, and so much more. Please help me welcome Eileen as well as our panelists.
Good morning. Oh, he's coming. Good morning, everyone. It's good to see everyone here this morning. Again, thank you for the invitation to come and share a little bit about what we're doing around traditional medicine. And so just very quickly, they asked me to share just a little bit. So I've been at South Central Foundation now for 29 years, and we have had a traditional healing clinic for about 24. And again, that's based on whole person wellness. It's a priority for us. To get to the clinic, you need to go through your primary care provider. But what we've found with the traditional counseling and the traditional physical services that we provide is that for the highest 10% utilized within our system, we've been able to reduce the amount of primary care visits by about 6 less, 12 less specialty clinics, 4 less emergency services. And so again, I think that having traditional medicine within your system not only will reduce some of the areas that have high impact, but also will provide better healing. And so again, today with our panelists, I'm just so pleased to be able to share with you the ones that we have here today. So we have Director Rosalind So, and she's an enrolled member of the Navajo Nation. She leads as the 11th Director of Indian Health Service in an agency within the U.S. Department of Health and Human Services. IHS operates the 17th largest healthcare system in the nation and serves as a principal federal healthcare advocate and provider of healthcare services for the American Indian and Alaska Native peoples. We also have JC here today. And J.C. Cooper is the Director of State Demonstration Group at the Center for Medicaid and CHIP Services and leads the agency's work on Medicaid demonstrations authorized under the Section 1115 of the Social Security Act. And prior to joining CMCS, Ms. Cooper served as the California State Medicaid Director. Prior to her time at the California Department of Health Care Services, Ms. Cooper worked as the Vice President of the public hospital. And we also have Roland Begay here today. And he is the coordinator of the Office of Native Medicine at the Chenille Comprehensive Healthcare Facility on the Navajo Reservation. And so this morning I would like to invite Director So to present on traditional healing in the IHS system. J.C. Cooper will talk a little bit about the CMS traditional healing demonstrations. And then Roland Begay will present on the role of traditional healers in the Chenille Hospital Navajo Nation. And so I'd like to invite Director So to go ahead and start us out.
Good morning, everyone. Thank you, Eileen, for that. Again, yat she rosen so yin she desh cheating shlons on the so pashin lokadesh che don't leslana dashinada. Thank you so much for allowing me to be here with you this morning. As I was preparing for this, I was thinking about a couple things that I want to make sure I set off right away here. One is the mission of the Indian Health Service. Not very often are we first, in my opinion, in the work that we do. But I want to turn you to the mission of the Indian Health Service that in part says that we will raise the physical, mental, social, and spiritual health of American Indians and Alaska Natives to the highest level. For me, this means exactly what we are talking about today, that while we know that there are still areas we're working through, while we know that there are still challenges that are happening across the country, how important that last component, the spiritual component, is, and exactly what, and directly talks about what we're doing today. The second part is that I am, coming from how I grew up, how I was raised, and we're talking about traditional medicine today. And then the 30,000 years that we're talking about that this has been in place, and yet in 2024 we get to talk about it more broadly. And from that perspective, one of the things I want to be very clear about is that while we have these new authorities with regards to being able to get reimbursed for third party, or get reimbursed for these services that we're talking about, this cannot be a government-run program. This has to be driven by tribal communities, by tribes, on how it is that you want them implemented in our programs. So I think that as we move forward, that has to be a fundamental principle in terms of how we do what we do. I've also heard, as I travel through Indian country, how important it is to integrate. It's already being done. It has been done for a really long time in terms of the integration of traditional medicine into our healthcare systems. But we also have to honor and respect our elders, our traditional practitioners that say that this information or these services should not be documented. This information and these services should not be publicly discussed. So I want to be upfront about that, and understanding and appreciation that while we appreciate and while we want to make sure that we continue to expand services, that we need to be mindful of also these principles that are first and foremost. Now, for Indian Health Service, we do have traditional medicine integrated into our healthcare systems, and I've also seen it in tribal programs, and I've also seen it in urban programs as I travel across. So this is, again, not new. I think the part that is new is that at least in the 4 states, we get to bill and collect for these services. And so as we look at this, I'm mindful of the fact that particularly during COVID, this was something that I saw, when I was the area director for the Navajo area, and how fearful our people were of just not understanding, not knowing. We all didn't know what was happening with COVID, and how many of our people then elected and wanted and hoped for more traditional services that were going to be provided in our healthcare facilities. So we had to adjust in our area, at least at the time, we adjusted. But moreover than that, we want to make sure that we're also integrating other parts of it in terms of, for example, at all of our IHS facilities on the Navajo Reservation, we have constructed hogans. Hogans are in place where the services will be provided in these facilities, in these traditional homes that we have, to make sure that, again, we're integrating the elements that need to be incorporated into our healthcare facilities. And then the last thing I want to say is, as I, over the past couple of months, really talking about, particularly this month as well, we're reminded about our many veterans that continue to struggle across the country. And one of the things I hear as a theme, almost a common theme, that they prefer traditional medicine over Western medicine, and that they need these services to be able to help them address some of the challenges that they are in. And then more recently, I've been able to learn a little bit more about what we're talking about, the North Star Prevention Program, where it's 5 tribes in Washington State that are that have taken elements of the Icelandic youth prevention program. And what the Icelandic Youth Prevention Program talks about is about all of these elements of how do we address, how do we reduce substance misuse in our youth, and how do we make sure that we are collectively working towards that. So I think as we move forward, what I'd love to see is not only making sure that we respect where our tribes and our tribal communities come from and where they will stand on this as we begin to talk more about integration of traditional medicine into Western medicine, but also that we build in that prevention part. As I look at this, as I've thought about this and grew up in a home where my grandfather would be singing a song and chanting and singing his song, and my father would be reading his Bible on the other side. That was the home that I grew up in, and that there was always a clear distinction that I was taught, but there was also clear respect that I was taught to have for both sides. And so as we, again, find ourselves as Native people crossing and straddling, Western and traditional medicine, this is something that I want to make sure that at the Indian Health Service, we continue to strive to strengthen our entire healthcare system. But moreover, that we are respectful and mindful of how we move forward in this particular step. So we can talk about all the things that we're doing and all the things that we want to do, but we can also quickly overstep if we're not careful about what we're trying to do. So I want to just leave you with that, is that at IHS, we're going to continue to support access to care. We're going to continue to make sure that services are incorporated, that traditional services are incorporated. But we will do that hand in hand with our tribal leaders and our tribal communities. Thank you. Shahab.
Thank you, Director. So I'll just say very quickly that Indian Health Service, the area office, has partnered very well with South Central Foundation in our tribal health system. And the original amount of money that we got from Indian Health Service 24 years ago was about $78,000. And they asked, can you do something with this? And that really was a seed to being able to start implementing a traditional healing clinic within our primary care system. And so now I'm going to ask JC if you'd present on the CMS traditional healing demonstrations.
Good morning, everyone. I'm so happy to be here to talk about the 1115 demonstration opportunity to provide traditional healthcare practices for Medicaid individuals. Really, the goal of the demonstration is to recognize and support indigenous knowledge and to allow for, in addition to Western medicine or the other state plan services, provide traditional healthcare practices or traditional healing and be reimbursed for that. The goal is really to be able to increase access to services across the U.S. and in the states that elect to offer this, as well as to really close some of the disparities that we're seeing. Some of the American Indian and Alaskan Native, depending on state, have some of our larger health disparities, and we really do think a combination of traditional medicine and Western medicine coming together can seriously improve some of those health outcomes, and there has been a lot of evidence to demonstrate that. And so by allowing for federal reimbursement through Medicaid, we're hoping that we can make that very clear from a policy perspective and to be able to report that. We have 4 states that were recently approved: California, Arizona, Oregon, and New Mexico were all approved to provide traditional healthcare practices recently. They will be working on implementation plan, and I'll kind of walk through the various framework pieces that are within this demonstration and decisions states will need to make with their tribal partners to be able to move forward with these types of services. So when it comes to eligibility, eligibility is any Medicaid or CHIP beneficiary, depending on who the state elects, receiving services through any of the 638 tribal clinics, IHS facilities, or urban organizations. It includes both American Indian, Alaska Natives, and non-American Indian, Alaska Natives. That's really the choice of the facility. So we're not changing any of the rules there. Facilities have a choice as to whether they provide services to non-American Indian, Alaska Natives, and we would allow for them to continue to do that here if they so choose. When it comes to federal match on these services for American Indians and Alaska Natives, it will be at the 100% federal match. For non-American Indian, Alaska Natives, UIOs, and CHIP beneficiaries, it would be at the regular service match. So again, the same rules that exist for all Medicaid services when it comes to these various facilities would apply with the traditional healthcare practices as well. When it comes to what services will be allowed, we are really allowing the tribes and facilities to determine what services they would like to provide. We have heard through our tribal consultation that maybe even if a traditional healthcare practice or healing is happening, they may not want it to be included in this particular reimbursement. So we will allow the facility and the tribes to really make those decisions in regards to which of the services in alignment with IHS guidance and rules around those pieces. When it comes to the providers, providers must be either contracted or employed by one of the facilities that I mentioned. That is a requirement. And really the facility and tribes will be the individuals who will identify the qualifications needed for the traditional healthcare practice or healers. We know that this can vary greatly from tribe to tribe, and so there will not be just one government qualification, for example. We will be deferring to tribes and the facilities to set those qualifications for each of the respective services and to document those qualifications so that it's clear, but that is really going to be at the discretion of the tribes and the facilities to make those qualification determinations. With these demonstrations, we're also allowing states to elect to do implementation funding. So oftentimes when we're doing larger demonstrations, states can elect to ask for federal dollars to do implementation augmentation. So helping update systems to be able to bill for these traditional healthcare practices, or to identify new flows within their system that are needed to be able to implement. 2 of our states have elected to do implementation funding. New Mexico and Oregon did elect to have implementation funding for their traditional healthcare practices. And new states, as they come forward, that is something that they could elect to do. When it comes to evaluation, federal regulations do require that we look and evaluate demonstrations in Medicaid. And so we'll be looking at, are we seeing an increase of access to services, traditional healthcare practice services? What are the number of providers? So are we seeing the providers across each state? We'll be looking at some of those health outcomes, similar to what was mentioned earlier. Are we seeing some of the outcomes that we would hope to see? Are people improving in their health outcomes? Are they having a reduction of emergency room visits if that's appropriate? Looking across just to understand the impact of adding traditional healthcare practices and traditional healing into the system. We have encouraged all states to work very closely with their tribes to design the evaluation in their state. And so we know that's an important factor that we hope states will, that have been approved, will quickly be engaging with their tribes to have consultation to design that evaluation. States put forward an evaluation design to the federal government for review. Additionally, after approval, there are some things that states will have to do as well. One of the pieces that they will have to do is they're going to have to attest to a number of things. The first one is they have to attest to choice, really giving the individual who's wanting these services the choice to provide traditional healing or not. They also have to ensure that there are non-secular services available. Really, the intent here is to make sure that individuals know that they do not have any limitations on the services otherwise available to them in the Medicaid program. If they need other traditional health care or other behavioral health services, for example, primary specialty, that they have full rights to continue to receive all of the services available to them in that state. So choice for the beneficiary, ensuring that there are other services continue to be available, and then really the other one is around making sure that there's no restrictions to those services. So for example, if somebody is receiving traditional healing, they should still be able to get their other services. So we consider it in addition to all of the services otherwise available to them in their respective state. So states will need to attest to that and ensure that there are no barriers to access for any services for American Indians and Alaska Natives, both within their traditional Medicaid services as well as for the traditional healthcare practices being made available to them. Additionally, we have built this framework. So I just walked through some of the broad-based pieces of the framework. States do have choices if they're coming in for a demonstration request. For example, they do get to decide if they include UIOs, CHIP, or have those implementation dollars, for example. Those are decisions that states do have in regards to the framework. Additionally, they can narrow the qualifications of the group. For example, one of the states has narrowed to start within one delivery system, their substance use disorder delivery system, and then phase in over time to additional Medicaid areas. Eventually, the goal is to cover their entire Medicaid population. So states do have the ability to narrow and grow or to cover their entire Medicaid population from the beginning of the demonstration. So those are the kind of parameters of the framework. We're really excited for the 4 states to be moving forward, and we look forward. We've already actually recently got some technical assistance from states, very excited about the opportunity that will be coming in next year requesting the addition of traditional healthcare practices. Of course, we've told them, please start tribal consultation, engage with your tribes in regards to your proposal to make sure they have the ability to weigh in on some of these very important framework decisions that states need to make before coming for their request and approval.
Thank you, JC. I'll just say, as we got started with thinking about traditional medicine, we do have a very strong traditional healing elders council, and speaking with elders within our community about what it is that we would do because of the perception of the larger community and being able to work with our primary care providers. And so again, getting a referral from the primary care provider down to traditional healing, and then circling back to the primary care provider. And so that has worked very well. I did want to acknowledge someone that I brought with me. We have our tribal doctor, Natalie Wiggins, and she is our traditional healing clinic director. And so I wanted to thank her for coming today. And now I would like to ask Roland Begay to present on the role of traditional healers at the Chenille Hospital in the Navajo Nation, and just to share a little bit more about himself.
Good morning. Yate Bennett. As I was coming here this morning, I found this. Does it belong to somebody? Okay, now that I got your attention. Good morning. Yate Bennett. My name is Roland Begay. I come from the Diné tribe, the Navajo Nation. I represent the Red House clan. I'm a Kintley-Chini, born for Naneshtajikachini, Nakaidanair, my grandpas, and my Dishkijni, or my paternal grandparents. I'm a husband, a dad, grandpa, a nully. I have 6 kids and 13 grandkids. I lived out in Jedito, Arizona, and I work at Chenille Hospital service unit there. I've been there for the past 11 years, and also oversee the Office of Native Medicine Department, which was established back in 2000 with a gentleman by the name of Johnson Denson, who actually structured what it is and got hired there at 2013. Since then, I've been the Office of Native Medicine Coordinator and oversee that department, and also have a practitioner, 5 practitioners, but one actually retired recently. So I have 3, and then also 1 trainee. They're kind of hard to come by. There ain't many of us anymore these days, and during my upbringing, just fortunate enough, I had great grandparents, dads, uncles that were actually practitioners, medicine people within our community. And I think a lot has to do with the family structure. If it's promoted and if it's supported, then that's usually how my upbringing was, as a kid growing up. And then through this ceremonies, a father of mine got ill and started going in and out of hospitals. So there, for a long time, he says, "Can you help me?" I didn't have that much knowledge, and never wanted to be a practitioner, really, because I never saw my dad a lot of times. He was always out busy in the community helping people. And I didn't want that kind of life, actually, but over the years, I adjust and adapt to it. So I practice what is called the upward reaching way in my native language, which is called Huchonja. And it kind of deals with a lot of the negativity side of spirits. And also, it's a healing ceremony. And it's a 5-day ceremony, and a lot that needs to be learned along with it. I've been ordained and initiated to have that bundle for the past 31 years. Since that time on, there's other ceremonies that I learned, and also we call it the Anaja. It's a ceremony that's pretty much often done with illnesses, pretty much someone that has gone to foreign conflicts or battles, a lot of our veterans, and various type of prayers, and also the blessing away ceremonies. I was initiated for that for the past 18 years now. With the enemy way, it's about 10 years, and then various different prayers. And what we practice or what we use, I remember back in the days where the big D's hospitals are where I would sneak in paraphernalians just to pray for someone. How far we came in life and what we see nowadays, the 1115 waiver, when they were piloted in 22 tribes, I've been with it for 11 years, and I was jumping up and down back in October 16 when I saw the email, and how far we all came, and that we could, how IHS service units, healthcare centers, how they encourage and also recognize and respect the climate of the respect, that to practice the inherent beliefs and ceremonies. Even though we talk about Native medicine side, I think a lot of IHS don't see a glimpse of it at all. Maybe just a diagnosis, prayers, and just very, very little. But on the outside, it's huge, actually. And as a IHS employee, in order to practice a lot of this after tour of duty, we have to have an outside activity in place, which gets approved in February for us to allow to do a lot of these practice. And then we spend a lot of time. I pretty much, during my upbringing, my dad was my own mentor, my grandparents, and to learn these ways and being able to spend a lot of times. And a lot of times what we learn and what we practice is pretty much on our gourd, the constellation that's labeled on there, depending where you're at. It's just like an associate, bachelor, or master, or PhD. If you see Pleiades on there, then that means that, that practitioners had spent many years, practicing what they do. So it's a lot of time consuming and what we do as far as being a medicine man and being responsible for a lot of things in what we do. My role as the overseeing the department out in Chinle, is pretty much, we have guidelines that consist healthcare services and also the Navajo area IHS and then Chinle service units. We have policies and procedures, which include Joint Commission on Accreditations of Healthcare Organization guidelines, applicable to some aspects of our work that we do day in and out when we go there. And also guidelines, but mostly assignments, involve issues among our people and the different cultural sensitivities, areas that I deal with. Our major focus of a traditional healing counseling service is personal care and also native diagnosis, which includes hand trembling, stargazing, water gazing, and listenings, and stuff like that. Very little that we do. We don't do overnight ceremonies or anything like that, but just little ceremonies that we do at HHS that helps support a lot of our patient in order to contribute to the holistic health care and patient, including mental, emotional, and spiritual care. And a lot of times we were told it's the tip of this finger to the other tip. Right here is your awareness, what you were exposed to. Some of the ligaments and the effects that a person has. The most powerful thing that they have is their mind. If we can purify it, if we can beautify that, then they can stand themselves back up. So earlier on, a gentleman that I heard talk about harmony and balance, that we all get out of balance now and then, and that's where, it seems like we have an issue. And I'm just so glad that, there are a recognition of value of traditional belief ceremonies and practice in health and healing of body, mind, and spirit, which is a huge area. And also the Indian Health Services. And then we also oversee Pinyon Public Health Center, Saley Public Health Centers, and then also the healing and the harmonizing forces within the individual lives, the families and their communities, and also the staff. Also promote the activities between Western and Native medicine as far as collaborating with these service units and health centers. And all the staff, and my staff of the Native practitioner include myself and 2 others, and then we also have a trainee, because they're kind of hard to find and the resources pretty much lack. So since I have 4 staff at the time, I said we can be that resource and be able to train someone and be able to, because a lot of time is the gift that they have. One can wait a lifetime for these gifts and never happen. So it's just kind of hard to find those people within our service units or in our community, but they are out there. So a lot of our patient flow, or 70%, I would say, my patients are elders. A lot of them don't read or write or understand English. And then since we're in the central agency, we're still rooted deep as far as culture. I used to work international pretty much all over. And then to me, how I see my people is like going to those foreign countries because they have their own language, their own beliefs, and their own custom. Because a lot of time it's our culture that kind of dictates a lot of what we do, even modifies our behavior, how we're dressing, even down to what we eat. So based on those things, all my staff, they have to be able to carry conversations, be able to speak the language and understand their needs and their wants, and then be able to engage and give them that space. And a lot of times that's what I'm finding out with my patients, because when I go see Western medicine, it helps me out, even though I have my own beliefs and my ways of doing things. I feel that later on in life, we still supplement. Well, just like the pandemic, when it happened mentally, we weren't ready, but it kind of pushed everybody to their limits. And at that same time, we believed, just like my dad said one time when he did an offer me when I was headed back to Nigeria. And there was a bird that kind of sat and then left. And he says, one day, son, something's going to come. I might not see it, but you might. But if you see a bird fall out of the sky dead, then you need to worry. If that doesn't happen, then you're okay. Everything's all right. So a lot of these things is pretty much our stories, you know, what holds everything together. And it's a long process. We have our own number system that kind of keeps everything in line. And that's why it takes so many years to learn and practice these things. And to be able to carry that into a hospital setting, to be able to help our people. We pretty much, you know, work with all departments at our hospitals, and also inpatient and outpatients, and even among our staff. We do a lot of department blessings and a lot of the outreaches. We do have outside partnership. You know, we have an organization here, the Tali Association. You know, it's one of our outside organization that we partnership with. They're also the Medicine Man Association that we meet every 6 months, and then update our cultural sensitivities and the logos that we have that they support. So based on these things, you know, as a coordinator for Office of Native Medicine from Chinle Service Unit, and there we do collect with other hospitals also across the reservation, the different hospitals, Tehoto Medical Center, Gallup, Winslow, Tuba City, Kenta, Red Mesa, and Shiprock. And we do also meet, you know, and then we were having a lot of meetings for the 11-15 demonstration too. So, and I just like to remember that, and Terilyn Chinez, the head spirit of the group, did a very good job. So it's good to be here.
Thank you so much. So I think we have time for just a couple of questions today. I don't know who the timekeeper is. 20, okay, great. So I'm going to ask Director So, for the traditional healing programs that are available or are beginning Arizona, Oregon, California, New Mexico, will you be looking to them for direction across other IHS programs? And then do any of those have traditional healing outcomes that you're aware of?
Yeah, thank you. So of course, we want to make sure that we're sharing what we're learning at the Indian Health Service and make sure that we're being transparent about that, again, in a respectful manner. And then the data that we are gathering, there is information that we are gathering in our electronic health record and looking at what it is that we want to continue to gather. Again, I think this really falls into that. There's not a way that we're going to ever, like we do for a Western patient visit, gather information that it is that we're looking for. And I think that will always be a challenge for IHS. But we are looking at what can we do? What are those kinds of outcomes that patients are experiencing that we might be able to collect that demonstrates, again, and fully supports the work that we're doing with traditional medicine. So I think there's still a lot of work that needs to be done in this particular area. But as we move forward, I expect that tribally led programs will determine that information consistent with what the requirements are, that we can get to a point where we can support the data that we're going to be collecting and the work that will be happening in this particular space.
Thank you. This is quite exciting. It's probably been, I think, maybe it was 2017 that I met Captain Carroll, and we had started talking about traditional healing, and was there a way that CMS would allow us to bill for that? And so today, it's actually a possibility, so it's exciting. I did want to ask JC, so for the implementation of the demonstration projects, is there a timeline that you have for that? And what should tribes do if they're interested in having their state propose a demonstration for traditional healthcare practices?
So each state will set their own implementation time period. I just got late breaking news from my team actually when I walked in today that California is primed to go live starting January of 2025. So in a very short period of time, that seems to be the first that will go live with traditional healthcare practices. Arizona, New Mexico, and Oregon are looking at those timelines. It does require the federal government, Medicare has released a code for traditional healthcare practice, which allows that to be billed. So people have to update their systems. They need to continue tribal consultation for what services or how they're going to do those various pieces. And so implementation will vary. It will really depend on how fast they can finish the consultation with their tribes, as well as get their billing systems up and running, or their rates out to the community as well. So those are some of the things that states will need to do to get their implementation in place. The other thing, the other question, if tribes are wanting to engage with their states regarding traditional healthcare practices, traditional healing, they should reach out. We have posted on all of the various HHS websites and broadly the framework, which I think is a good place to start and look at in regards to the decisions that a state would make, some of the many things that I walked through today. So being prepared to go in and have conversations around UIOs, for example, that's one of the decisions that needs to be made. And if there are UIOs in your particular state, discussing with the state if they're going to be including those or walking through the services that are provided in those UIOs so they understand the impact that could have on their demonstration approval, for example. Also talking through with the state if this would be statewide or if they plan on narrowing, and providing data and information that would help the state have an informed decision regarding that. So that is, I think, an important part. If you're thinking that tribes and facilities will need that implementation funding, having a conversation with the state around what you think your gaps are to be able to implement this. I think all facilities and tribes are in different places. Some facilities have been providing this for some time, and they can maybe get up and running a little faster, where some maybe have been doing it within just their tribal area, but not through one of the IHS facilities or the 638 tribal clinics or UIOs. And so that would take time to figure out how to incorporate that through. And so communicating with your state on the types of implementation funding that you may need, I think would be another point of engagement, as well as your readiness within the state to be able to take on a new implementation like this. I think those are things I would bring to the state for those discussions to inform their full application to CMS.
So I think that one of the things that probably can be a challenge for many tribes providing any kind of service is really funding. How do you get started? Is there startup funds available to help with this?
Those implementation funds would be similar to startup funds that can help update their systems or bring people on. So yes, those are the funds, but it is at the option of the state, and the state is required to put up a 50% match on that. So 50% federal funds for startup funds, 50% state funds. And so states do have to put forward a budget of what they would can do. And so I think having that conversation of what it would take for those startup funds is a really important conversation. As I mentioned earlier, of the 4 states approved, only 2 of the states put in for those implementation funding or startup dollars for the traditional healthcare practices.
That's too bad in a sense. So for services provided within the tribal health system, that's 100% match, and it would have been nice to see that for this also. I guess we have a couple of minutes. I guess I would ask, is there anyone that has a question for anyone on the panel here? If not, I'm going to ask Director, so do you have anything more that you would like to add?
Yeah, thank you so much again for being here with us again today to really talk about this very important conversation. You know, as I reflect on this, you know, what an incredible opportunity that we have in front of us at the Indian Health Service and across Indian country to be able to now sort of formalize some of the work that we can do for our people in a way that we can, in a way that our people want it, in the way that our people need it. As I was reviewing, again, preparing for this conversation, I don't take this conversation lightly at all. I think it's very important. It's always a privilege to be able to stand up and see through, particularly this month being, you know, Indigenous Month or Native American Month. You know, there's so much for us to celebrate as we are here today, whether, again, we're talking about our veterans, whether we're talking about our elders, we're talking about our youth, all of the things that we have. And with that, all of my colleagues at HHS that have been supportive of Indian country has been pretty remarkable during my time here in my role here as the director of the Indian Health Service. It has been an absolute privilege to see this administration continue to support Indian country in those areas that we want, not what the government thinks we should have, but what what Indian country is looking for. I hope that as we move forward, and I think I heard it earlier this morning, I think it's important to restate that the opportunities that we have in front of us and the hope that we're going to get to where it is that we want to get to together. My work at IHS, again, I cannot speak about it enough, has just been a remarkable journey. Been out there in Indian country. I have learned more than I ever thought that I would in this role. But as we continue to lift up Indian country at Indian Health Service, there's still a lot more for us to do. There's still a lot more that we need to get done with respect to the services that we provide to our people. And then again, in this particular space that we're talking about today of traditional medicine, it is a remarkable step that the federal government has taken. And I also want to thank Dr. Carroll and her team as well, because I remember having this conversation with her as well in terms of what do we need to do, how do we need to get there, and so forth. So thank you again so very much. I appreciate the question.
So I'm going to ask JC and Roland both, do you have, very quickly, any recommendations for us as we start thinking about moving forward with this, along with CMS and partnership?
This is like Mrs. So said, it's a milestone, how we look at it. But my question is, will this program, we have in Chinle be replicated to other Navajo hospitals or clinics across the reservation?
What I would say is, I think, from our perspective, as long as the state has the authority and it does require the state, then the answer is we hope yes, that we will see an increase of access to traditional healing. It may not be in a certain facility today, but we're hoping that tribes can share the knowledge of how they've implemented in those systems, and or the IHS facilities can share across facilities how they've done workflows and how they've incorporated it. And I know when we were in Arizona recently, there was a lot of really great conversations around sharing across facilities, across clinics, and around how those things could be stood up for those who have already done it and to share with those that were very interested. And so that is our hope, is that there will be growth, and even if it's out in the community, figuring out how there can be reimbursement for those services. So I think we would love to see that increase. The only thing I would say at the end is, this is almost a decade in the making, as was mentioned earlier. I mean, the original request came into CMS in 2015, and Arizona has been a significant leader in regards to shaping, informing, and advocating. And so I think everyone is very happy we're here, is what I would say is keep tight communication with us. We want to know how this is going. We want to ensure states are engaging with tribal consultation and working directly with facilities to get these services up and running. And we want to ensure that we meet the goals that I started with in regards to these demonstrations, and look forward to seeing some of the amazing outcomes that can come from access and reimbursement for these traditional healthcare practices.
Well, I think this has been very exciting, and we look forward to connecting with you. And thank you so much, Director Roland, for everything that you've done across Indian country. And I know you've been out visiting. You came to Alaska a couple of times, and I really look forward to connecting more with Roland and seeing what you're doing, and would love to connect with others within those other states that are already implementing this. And feel free to come and visit Alaska, come and see what we're doing. We just expanded our traditional healing clinic, and we've done some amazing things, and pulling in our elders, pulling in our youth. And so again, thank you so much for everything you do and for sharing on this panel.
Thank you so much to Director Sylvester, Director So, Director Cooper, Mr. Begay, for your leadership and sharing information, for taking the questions. And thank you to the staff that are in the room that have been working on this since 2017. As you can see, it's, the conversation, the ideas come from folks like you here in the room. And then our people here in Washington, D.C., our feds, our politicals, and our career really take the time to think about what it is that you've said and try to figure out what's feasible. How can we work within the existing structures and systems, and what needs to be changed? These conversations aren't in vain. These conversations really do mean a lot for a lot of the federal people working in this room. So thank you for sharing your ideas and your feedback. Up next, we have a special presentation from the Seattle Indian Health Board, who will share some information on what they do to incorporate traditional healing with their services. For our panel, please join me in welcoming Esther Lucero, President and CEO of the Seattle Indian Health Board, Layla Yamabe, Traditional Indian Medicine Director, and Andrew Guillen, their Chief Public Affairs Officer. Thank you so much.
Good morning, everyone. How are you? It's so amazing to be here in DC. Some people, it's funny, live really close by, but I had to come all the way to DC to see them. Yes, Laura Platero, I'm talking about you, for sure. But anyway, it's wonderful to be with such friends and colleagues, really doing incredible work. I'm going to ask my team to introduce themselves, and in lieu of not having slides, we're going to do the very best we can to kind of spell out how we've developed our Indigeno model, okay?
Hello. I told Esther we're keeping it tradish with the with the oral presentation. O Nguitu Hat Sachel Tawagwalapu Si'iab Lele Yamabe Tsitsa. Greetings. Good day to all of you honorable people. My name is Layla Yamabe. I'm proud to be the Traditional Medicine Director for Seattle Indian Health Board. I'm enrolled Quinault. I'm also Quileute, Squaxin, and Skokomish. My traditional medicine journey started long before I was even born with my family. I'd like to acknowledge my family now. I come from the James family from Tahola, Hobucket Eastman families from La Push, and Simmons and Tom families from Squaxin and Skokomish. I spent the first 4 years of my life, well, around ages 2 to 4, living in the hills with my family. We would harvest traditional foods like mountain huckleberries. We moved to Renton, right outside of Seattle. So I often felt that I had to walk in those two worlds, Western and traditional too. At the age of 16, I enlisted in the military. I trained to be what they call a combat medic in the Army Reserves. I went to school at Northwest Indian College, and I got my degree in my bachelor's in Native Environmental Science. But I like to give more credit to my ceremonial background and teachings. I learned from medicine people from Upper Skagit, Tulalip, Muckleshoot, Yakima, my own family, the Chehalis Reservation, and even as far down as Warm Springs. So I just wanted to share just a little bit about myself and where I come from, my family background. I'll pass it on.
Good morning. My name is Andrew Guillen. I come from the Cahuilla and Luiseño people, Southern California. I'm the Chief Public Affairs Officer at Seattle Indian Health Board, where I've been employed for the past 19 years. I've been saying this a lot lately, but I'm not sick. I've lost my voice a few weeks ago, and I'm struggling to recover it. So yeah, I'm not passing germs around or anything. And I just want to say, in my time working at Seattle Indian Health Board, it's always been a dream, something we've talked about, to be able to provide these services for our people, and to be able to get resources around them. So I want to take this time to acknowledge everyone who has worked on this for decades. I know that it's very exciting for myself personally to come in at the tail end and be a part of this journey. We still have a way to go, but it's exciting to be here talking about these things today.
Yeah, and so although I know many of you, I know some of you I don't know at all. So, Yate Bene, my name is Esther Lucero, and I'm Dene on my mom's side, Latina on my dad's side. And this is my 9th year serving as the president and CEO for the Seattle Indian Health Board. Yeah, it's an incredible journey. I get to work with these amazing people every day. And I, too, have to acknowledge that I was inserted into this conversation around traditional Indian medicine and getting to a place where it's a billable practice, much later. We have generations before us who've been really working towards these goals. And, I think about like champions like Dr. Terry Maresca, who's one of my mentors here, and is serving as one of our practitioners and also one of our primary care docs who teaches our next generation of workforce. I think about, the story she's told when I was pre-med in my undergrad, and I will never forget it, about how when you can get your patients, we call our patients our relatives at Seattle Indian Health Board, to bring in that little brown bag and tell you what's inside of it, then you know that you're practicing in a good way, right? Because they're already using their traditional medicines. And that really stuck with me. It held me tight and made me think about her work at the University of Washington with the Indian Health Pathways. And as I was kind of up and coming in my academic career, wanting to really commit myself to making sure that we cultivated an environment and a system that was designed to help sustain that work, And so, so I just want you to know that even though it's my life's work, and I just feel a responsibility to so many people who've come before us, to just lend whatever elements that I can to help bring this to fruition. So let me just tell you a little bit about Seattle Indian Health Board. Seattle Indian Health Board opened in 1970, so it's a little bit older than me. I like that I can say that now because I have my gray hair, just a tiny bit older than me. And we are a federally qualified health center as well as an urban Indian health organization. We also operate the Urban Indian Health Institute, which is one of 12 tribal epidemiology centers in the nation, and the only one that has a national scope because we serve all of the urban programs across the country. Now, I'm sharing that with you because that makes us uniquely positioned to really design and test a model that is really data-driven and culturally informed. So, we've been working for the past 9 years, and even before that, I'd have to say, but to design what we now know as our Indigino model, our Indigenous Knowledge-Informed Systems of Care. So Indigenous Knowledge-Informed Systems of Care might sound a little familiar because I would say probably about 10 years ago, all the buzz, all the rage was trauma-informed systems of care. How many people know about that? Yeah. Okay, good. Now we have some interaction because I'm so tired of just talking around. Let's just talk around. So anybody who wants to jump in at any point, you're welcome to do that. Trauma-informed systems of care basically said, hey, we recognize that we all come from our own experiences of trauma, and we commit to designing systems that do not re-traumatize one another, right? That's what it said. And when I'm working with my colleague, Abigail Echohawk, she and I were talking about it, like, wow, that's just half of the story. We're always so much talking about, like, our deficits, right? Coming from a disparities place, always talking about trauma. But the reality is we're all sitting in this room because our ancestors have been resilient and strong, and because our cultural teachings have continued despite countless efforts towards genocide and assimilation. And so we're standing here based upon that strength. And so when we designed our Indigenous Knowledge-Informed Systems of Care, we wanted to take that strengths-based approach. So yes, it's true that we come from experiences of trauma, but it's also true that we have the power to overcome it. And that's where that term came from. So our Indigenous Knowledge-Informed Systems of Care, was really around building an organization that was just unapologetically Indigenous, right? We're not going to apologize for who we are. We're not going to apologize for like the variations in our indigeneity and cultural identities. We're not going to apologize for any of that, right? But what we're going to commit to is centering every single thing we do on our cultural epistemologies, on traditional Indian medicine. So we took a lot of steps to do that. We had to come up with a working definition for traditional Indian medicine. We worked and listened to our communities. We listened to our staff. We listened to our board of directors. We listened to our cultural practitioners that folks are connected to, and we began to build that system. We put together a cultural work group at the Seattle Indian Health Board, and from that, we built a cultural framework that we implemented throughout our organization. Now I feel really blessed because I see some folks from California. Beverly Miller's sitting back there, right? IHS director, and I think Natalie Aguilera is in the room. And I just remember in my time in California, working for the California Consortium for Urban Indian Health, I had the privilege of leading facilitating a project. It was called Traditions of Health. Now, what I learned in that process, we listened to traditional Indian medicine folks, we listened to cultural leaders, we listened to community leaders, we listened to primary care doctors, behavioral health providers. I learned in the work in California was, wow, we were all doing some form of traditional Indian medicine work within our organizations. Mostly, though, it was grant funded, right? We didn't have a sustainability plan. So what I learned from our traditional healers was, oh my goodness, yeah, we're happy to do this work. And what happens is you guys put us into whatever room you have available, and we're expected to carry our bundle with us, right? We don't have an environment necessarily that cultivates the healing that we need to have. I'm seeing heads nod. These are some of your experiences, right? And I remember one of the healers said to me, are you expecting your doctors to bring their cotton swabs and their syringes with them and practice out of a closet? Is that something you do? And I said, wow, no, we don't. The other thing that our healers found really challenging is they might encounter somebody in ceremony, right? Maybe somebody who's experiencing suicidal ideation. And they would do the right thing, and they would refer them to a behavioral health provider. And then they would get entered into behavioral health therapy or treatment or whatever it was they needed, and then the traditional medicine person was left out of that conversation, right? And so they really found themselves wanting to maintain, like they recognized and respected what Western medicine had to offer, but also recognized and respected that they have something to offer too, and that we needed to work together. What the healers also told me was that our young ones who were born to actually become practitioners, to become healers, were not following that pathway because they didn't have a way to sustain their lives. That for many of our communities, the ways that we've taken care of our healers over time were disrupted, right? By capitalism, quite frankly. That we needed money to be able to survive. And so they were really concerned that we were going to lose these pathways for our young ones. And so, although they said it is very important, as Director So said, right, that we maintain the cultural integrity and we protect this knowledge, that is very, very important, that it's also important that we continue. So when I listened to that, right, and working with all of those folks all across California, we wrote the Traditions of Health. It was a policy change strategy and sustainability plan. And because I had the honor of being able to be invited to apply for the position at the Seattle Indian Health Board, we were able to take that work and implement it into an organization. I recognize that that's a unique experience. I do recognize that. I recognize that many of us are in organizations that, have been doing things the same way for a long, long time. And so when I think about entering into the Seattle Indian Health Board and the previous work from California, learning from folks like Carolyn Cruz down in Oregon, I think about all of that work. And I recognize that the Seattle Indian Health Board was already looked upon as a national leader, right? We were well known for our policy work. We were the very first urban Indian health organization to provide congressional testimony, right? Luana Reyes was that person. And we literally still have her typewritten testimony. So we knew that we already had a good platform for policy and advocacy. And then we've heard a lot of conversations around, you need the data to prove it, right? Was that CMS who said it? Probably. You need the data. And so the fact that we had our Urban Indian Health Institute, we could position ourselves to do a really good evaluation. You know, I also think about the fact that we were the very first Urban Indian Health Organization to become a federally qualified health center. So we understand billing pretty well. We understand that coding system. Although I have to tell you, when CMS just said that there was a code that was released for traditional Indian medicine, I was like, I haven't heard that. Holy cow, we worked really hard to mimic the behavioral health system in our coding model. I'll tell you about that in just a moment, though. But yeah, so the Seattle Indian Health Board positioned really, really well. And when I arrived at the Seattle Indian Health Board, our traditional Indian medicine person was kind of buried in a grant, right? Yeah, I'm hearing that. Our traditional medicine folks are nodding their heads because they know that they have to meet these grant objectives. And they also know that the funding will end. So you don't know if they're going to bring you back or if they're going to get more funding to bring you back, right? Yeah. I have to tell you all, you know, thank you for continuing to do that work, even faced with those challenges. So back to our Indigenous knowledge-informed systems of care. So yeah, we built our cultural framework, and then in order to be unapologetically Indigenous, we had to re-onboard our entire staff, which we did. And we did it in the middle of the pandemic. And we had to teach our staff what it meant to be unapologetically Indigenous. Simultaneously, we had to look at our electronic health record system. I don't know why we did all these crazy things during the midst of a global pandemic, but we did. So we revamped our entire electronic health record system, and we went from Allscripts to Ocean Epic. And we worked aggressively with Ocean Epic. I had to add a chief information officer so that we could actually do that in a good way. Because we had to talk with Epic about how to add what we mimicked behavioral health codes into our electronic health record system without compromising our integrity. So what that means is that we didn't share too much information. We're not trying to share all of our ways of being and knowing, right? That is not for everyone. That is the knowledge that belongs to each of our tribal people and to each of our tribes, and that's protected with tribal sovereignty. As a program, as an urban program, we recognize we are not a sovereign entity. We do not exist without tribes. We are simply an extension of that sovereignty through the healthcare delivery system. All we are doing as an urban program is trying to serve our relatives who now live in urban areas and do it in a good way. So it was equally as important that we didn't build some weird pan-Indigenous movement, right? We're not talking about some weird new agey, like crystal kind of thing. That's not what we're doing here. What we needed to do was build a network of practitioners that came from as many different tribal communities as we possibly could. Because if you look at the Seattle Indian Health Board's database today, we have over 364 federally recognized tribes represented in our database. 67% of the relatives that we serve identify as American Indian and Alaska Native. The other thing we knew is that even non-Native people benefit from our traditional ways, right? And we didn't want those folks who experience our traditional ways to think that now they could suddenly practice. So we had to think about all of these things. And for that reason, we built a network of traditional Indian medicine practitioners who also act as our advisors. So we wouldn't mess up. We wouldn't compromise our cultural integrity. And we looked at things like the NUCA system of care. I mean, South Central Foundation is an incredibly integrated model. And we also knew that we wanted to make sure that it was even more integrated. So when we look at our care teams, not only do you have a primary care doctor, behavioral health specialist, you have a traditional Indian medicine apprentice. And in the near future, you will also have a dentist, right? And we have like support services, like clinical pharmacists, for example, who could help us understand if there was going to be like a negative conflict between like a Western medicine and an herbal medicine. Yeah. And that's what we've been working towards aggressively for 9 years. I'm going to hand the mic a little bit to Layla so that she can talk about what it looks like in the day-to-day.
Hello again. So as Esther was describing, we have a traditional medicine apprentice in every care team. We have 3 clinics, the International District, Pioneer Square, and Lake City. So all week long, we have an apprentice that can be there for the relative. You can think of the apprentice as working for prevention, early intervention for what the relatives might need. And having the apprentice there in the morning, they huddle with the providers and determine if there are relatives that have established care with traditional medicine before. They know that because we are in the electronic healthcare records, and we can add our traditional medicine as part of the care team. So when we pull up the chart, they can say that the relative has seen traditional medicine. So the apprentice can spend like 5 to 15 minutes with the relative, and it's different for everybody. We all have the different permissions and different rites of passage that we've been through to offer that care, but we can pray. Some might have songs that are appropriate to share with the relative. We also offer smudge, or in our coastal ways, we brush off with cedar. So,
And then I want to be clear that our apprentices are folks who basically do prevention, early intervention. And if there's additional work that needs to be done, they can refer to one of our practitioners, right? So there's an appointment for that. I say that because it's very similar to behavioral health work, right? You can have somebody who's a clinical social worker who can do prevention, early intervention, and then if there needs to be ongoing work with them, they can refer them to behavioral health providers. Does that make sense? Yeah.
So we have practitioners in the different, like the different specialties within traditional medicine. So we think of our culture keepers, our ceremony keepers, our language specialists, traditional foods, traditional plants, plant medicine. So if a relative is coming with something very specific, the apprentice can refer the relative to one of those practitioners.
And so we've been doing this now. We have 2 years worth of data. And Andrew came to us originally as a clinical psychologist, a researcher. And so I often lean on him to verify whether or not the data is valid. And so this time he said, yes, he can come speak to you because we're not just using preliminary data. Go ahead.
Yeah, so it's very exciting. As I'd mentioned, something at SIHB we've been talking about for a long time, and the one of the big challenges to billing is we have to show these Western systems that these interventions work. Well, as Native people, we know they work. They've been working for thousands of years. I know for myself, I've seen it. In family members, I've experienced it, and as a former provider and researcher, it always struck me as we can set up these basic things and prove this, right? And without trampling all over culture and ceremony, right? These things need to be protected, and don't need to be manualized or turned into a science experiment of some sorts. So what we've done in our clinic is when we had shifted our electronic health record to OCH and Epic, I think it's been about 3 or 4 years now, it gave us this incredible opportunity to improve our data systems. We have our in-house Urban Indian Health Institute that can provide this top-notch evaluation. And so it's largely not seen or felt in the clinic side with the relatives we're serving. We're having them fill out just some really basic clinical assessments, the same type of assessments that I'm sure most of us here today have experienced when we go to see our primary care physician. So, we use little short form scales like the PH9 or the PHQ-9 personal health questionnaire, right? It takes 5 minutes to fill it out. You go in when you see your provider. We also use the GAD-7, which is the General Anxiety Disorder Scale, so that we can get a reading on self-report on anxiety. And this allows us to have self-report from the relatives we're seeing, but to try and quantify where they are and just to give us a measure of comparison. And so we started in December of 2022 collecting this database with these short scale measures. And we've had Urban Indian Health Institute do some data analysis for us going from December of 2022 until October of 2024. We've captured close to 2,000 different unique individuals that have been seen by our traditional medicine team. Of those close to 2,000, what we're seeing is about 66% of them only had, during that time period, one interaction with our traditional medicine team. So the bulk of that 2,000, we might have that initial baseline, but if they haven't come back for additional services, we don't have the follow-up. So we have taken the folks that we've seen at least 2 times during that period who have had an interaction with our traditional medicine team. And so the numbers for folks who have come in more than one time during that time period is a little bit over 200. And so that's kind of the population that we're able to pull from to say, okay, we have a meeting with our traditional medicine team baseline, and now after they've met with our traditional medicine team at least once, sometimes more than once, but at least once, we have that post engagement with traditional medicine. And it's very exciting what we're seeing. Right now we've shown in our clinic significant results around 2 topics. One is anxiety, the other one is suicidal ideation. And so I'm going to talk about the anxiety first because I think it is a strong effect that is statistically significant and relevant, that we are seeing people who are coming into our clinic, they are self-reporting on the GAD-7 scale that they are feeling less anxious after they are visiting with our traditional medicine team. Again, this measure is just a 5-minute thing they do as they come in, as they're being roomed for their medical exam or to meet with the traditional health practitioners. So it's not in any way involved in the services that they're receiving directly from the team. Tries to be very unobtrusive, but we are seeing significant drops in the levels of anxiety that people are reporting, and we hear this anecdotally from providers in our clinic. And I think one of the best examples that I've heard, and kind of comes unexpectedly, is we have dental services, and I know how many people get nervous when you're sitting in the dental chair or you have to go to the dentist. I know it can be very anxiety provoking for a lot of folks. And I've heard multiple stories of a relative sitting in the dental chair, and our dental staff is picking up on that they're feeling really anxious and uncomfortable. And all of our providers know that they have access to our traditional health practitioners. And so they are able to ask someone who's sitting in a dental chair, hey, you seem to be anxious today. Would it be helpful if we call one of our traditional medicine practitioners just to speak with you for a moment? And you know, I think of one young lady who kind of gave us testimony about this, who said, you know, she was crying in the chair. She's had tough experiences at the dental office in the past, and it's just it's a very scary thing for her. And when she had met with our traditional practitioner, they sang a song. It relaxed her. She was smudged, and she said that you know, she knew she was in the right place. That we were there to help her and protect her. You know, we were going to help her get through this dental appointment. And then after speaking with the traditional medicine practitioner, she could feel that all of her ancestors were there in the room with her, and she knew she was safe and that things were going to be okay. And so anxiety is you know, a comorbidity, you know, occurring at the same time with lots of other disorders. And the thing about anxiety is, you know, it's one of those things that, like, for a lot of folks who suffer with anxiety or panic disorder, it's often the anxiety that you're going to get anxious that can trigger that panic attack, that anxiety attack. And so if we have some tools, sometimes it's just a memory of talking to a traditional medicine person, or you know, remembering about culture, something that's going to make you feel at ease and calm you down. That can be such an amazing tool, not only in the dental chair, but in our everyday circumstances. The other place where we're seeing statistically significant results are in suicidal ideation. So very important, if someone comes in and says that they are having thoughts of wanting to harm themselves, this is a very serious thing for anybody, especially for folks who may have had a history of trying to do that. And so, you know, these are folks that it is a red flag that we need to talk more about this, see where they're at, make sure that they're safe, that they're going to be safe. And when folks who are reporting high rates of on their suicidal ideation scale, we're noticing it particularly for the folks who are coming in with high scores. That you know, like on a 10-point scale, if you're coming in and on a measure of like suicidal ideation, you're scoring those low rates of like 0 to 3, you're getting a little bit of an effect. Not much, but there's not a lot of room to move down. For folks who are elevated at the top of those scales, that is where we are seeing the statistically significant effect after individuals are exposed to meeting with our traditional medicine practitioners. And so right now, I think we have a population of about 197 in this analysis. So it's still very preliminary, but to have a significant effect on someone who's coming in and saying, yeah, I'm thinking about hurting myself, right? That is having a direct effect on potentially keeping this person safe. And you know, right now we're just kind of pulling some basic measures out of our electronic health record, but you know, we would like to get to the point where we are expanding like these measures. You know, we know that traditional medicine is an incredibly effective resiliency factor, right? And so having a measure of like cultural connectiveness could be another variable that we are using in our analysis to see, okay, this relative is meeting with our traditional health practitioners. You know, we're seeing some of these results in the clinical short form scales that we use, but if we're also using something like cultural connectiveness, we then can see how they are feeling in regards to their own connection to culture, and how, if at all, that is also affecting how they are what their results are on these short form scales, how that is affecting their healing in the Western world, right? Is that we have to document it and use the scale to show that. We're just at the early stages of this, but the results are looking good right now.
Yeah, and I mean, we've heard this before. Dr. Joe Gaunt says that strengthening cultural identity is best preventative mechanism, right? With Dale Walker's work was very similar as well. Dr. Maria Yellowhorse Braveheart, in order to overcome historical trauma, you have to reconnect to your cultural identities. And so, this is not a surprise to all of us. But what it does do is it's provided us with the data to be able to get buy-in from managed care organizations. So we have 3 managed care organizations who have agreed to pay for traditional new medicine as a value-added benefit, right? 1 at the full encounter rate. Now, it was the Community Health Plan of Washington that allowed us to test this system within their system. So we've successfully been able to run through a full billing, which is amazing. They've also helped us vet our credentialing process and system to make sure that it aligns with what the Western needs are, while simultaneously, Layla has been able to work with our practitioner network to make sure that the privileging and credentialing process is also respectful of our cultural ways of knowing and identifying who our folks are as traditional medicine practitioners. Go ahead.
Yes, thank you. So I'm going to share just a little bit about how we created the privileging application for practitioners, because we needed to do that to perform these tests with those MCOs or the CPHW. Sorry. The first thing I did, I went to community leaders. I went to the practitioners that are doing the work, that we know that have been serving the people. Most of them, it was a lifelong commitment, family lineage, to be able to do the work that they do. So I met with master weavers, master carvers, artists, the head people of our longhouses, our coastal longhouses, and some of it, is a little familiar, being a little weaver myself and beginner language speaker too. Some of it I was a little familiar with, but I went to them to ask them, what did it take? What does it take? What did it take for you to be a master carver? So hearing from them, that was the important thing, the important first step for me. The next step was learning the Western way of credentialing and privileging. So I had to talk with our HR people, and they taught me about CredStream, which is how we credential providers. We met, and I basically took certain things that you could find on both sides, the Western and the traditional way, so demographic information. I added we added ceremonial name to that application, and then basically translated the Western way and how we do it in a traditional way, because in our traditional ways, we still verify people too. So instead of looking for certifications or licenses, we were asking for witnesses to your work, mentors, teachers. I do have a copy of the application for some of it. I see some notes being taken. We're happy to share it with you, show you the work.
So because Layla, put the work into building these relations and making sure that we, vetted it in a good way, then we were able to go back to our systems. So we're uniquely positioned in Washington. So Washington has 29 federally recognized tribes and 2 urban programs. And in, I believe it was 1989, adopted the Centennial Accord. So what that meant was at the state level that they were going to uphold tribal sovereignty and built in mechanisms to be able to have tribal consultation. And in some cases, we're invited by the tribes to also provide information as an urban program. What that means is we are part of the American Indian Health Commission, which is basically an advisory group to the state of Washington. And that body has representation from the 29 federally recognized tribes and the 2 urban programs. So it's a perfect place to have governance and oversight over the privileging and credentialing process. I'm in conversation right now with the Department of Health at the state of Washington to use existing mechanisms. So we do this for other things like acupuncture or for naturopathic medicine. And so being able to use that mechanism to be able to house the documents, to be that source of truth for our credentialing privileging process. And I'll tell you, in talking with the commission and our tribal leaders in Washington, one of the things that they wanted to protect against is if, tribal leadership changes, turns over. And at that time, sometimes there can be family conflicts, and some folks might identify people as practitioners and some might not, right? And so we wanted to make sure that we were protected against that, so that once we privilege and credential to folks, that we could have like some sustainability and longevity in that as well. So we're not an 1115 waiver state yet, and we're really working with our state as they begin to think about applying for that process. And the one thing that I will encourage folks to do from different states is please don't leave the urbans out. I want you to know that we're not trying to dip into any resources or anything like that. We're really just trying to be part of that continuum of care. Because quite frankly, it's the thing that incentivizes states to work with organizations like ours to make sure that we can maintain our cultural commitment. So let's not leave the urbans out of the conversation. We're also happy to do what we're doing now, which is build the systems. Because what we hear on the western side is, oh, we don't have any proof. That's a nice story, but we don't have any proof. Well, now we're demonstrating that we do have the proof. Now we're demonstrating that we can build it into the system, right? And now what we're just looking for is reimbursement for sustainability. And the data that Andrew just spoke to is really demonstrating something that can make an impact to the quadruple aim, which is essentially to reduce healthcare costs within emergency room settings. One of the managed care organizations that we're working with, WellPoint, has agreed to do the economic analysis so that we can demonstrate the cost savings as a result of this work within the emergency room systems. And so what that does, and we're CMS, I want you to hear this, we will save you money. We will save the federal government money. And so I think with that, I would really love to have open discussion. I'm sure you all have a lot of questions. And so but we're happy to have that now. I think we have microphones on every table too.
Yeah, and I would say like the potential cost savings are also another data point, so that we can actually see if we're able to demonstrate a connection. Traditional health can be a preventative measure. We see in our clinic anecdotally that when relatives come in and they meet with our traditional health team, they're more likely to access additional services. They're more likely to keep coming back for additional appointments if they need them. So they're more medically compliant. They're more likely to fill their prescription at our on-site pharmacy and follow their provider's orders to take those prescriptions. So, that is another obvious data point around cost to see how that plays out, is that if folks are benefiting in a health promotion way from traditional medicine, along with that cultural connectiveness, then I would fully expect that they're going to be less likely to present at the emergency room in a acute condition. They're going to be less likely to be using the emergency room as a primary care physician. And so, as I had mentioned, we're just at the start of all of this analysis and thinking about, now that we're kind of getting this type of collection embedded into our health clinics, how there are a lot of questions around this, and like I said, I'm a strong believer that we're going to find out that with all of the statistical analysis and approaching it from a Western way, that it's pretty easy to demonstrate an effect because the effect is there. Like, so we just need to continue going about documenting it in a good way to prove that for systems that not only do we expect to see improved health outcomes, but we expect to see reduced costs as well.
Yeah.
Dr. Warren, all people who have, and many others that we've been working with over the last few years. I'm representing CMS right now, and we're delighted to hear that you anticipate improvement in your financial bottom line because of CMS's addition of traditional healing. And the codes are there. There are also ICD-10 codes for you to use. I want to thank you, and we look forward to hearing your the outcome of your research, because I've been looking for that for years, and just to have something that we can really build from. South Central Foundation has done a great job with their ER visits, and Layla, thank you for getting your credentialing organized, because that's a big part of how CMS is looking to see how you credential your providers. So thank you. No specific question, but happy to hear you're working there and also with the Icelandic model, because I think that is critical too. Thank you.
Thank you so much. If we'd had slides, we would have shown you snapshots of the EHR system so that you could see it and kind of the overview. We might be able to share the slides later so that you all can have it. But yes, our whole intention has been to build a model that works for everyone. I saw other hands over here.
Lenore Myers, Rocky Mountain Tribal Leaders Council. I guess I had some questions. I'm glad this is happening, and I know when I started on Tribal Council, I went to RES 2023, and Dr. Warren from, I think UND at the time, and two other medical providers talked about having medical schools in Native American communities. We don't have that. But he also talked about the importance of this happening, so it's good to see this happening, that we have our traditional medicines being taught. I guess to me that I have a couple questions. One, would you be willing to share your management of information systems? Because I think as tribes can, build these systems, they're going to need, best practices that you probably already developed. The other thing is I see the importance of probably working in associations, and I know you guys are touching on the, like the sacredness of some of our practices, that we can't always share them. But I think that, that we have to, as tribal people, so we don't lose this medicine, how do we get our young people to become these medical providers? Because if our elders were treated as equivalent to a doctor, we would have kept a lot of that knowledge in our communities. So I guess, to me, it's important for us to share our knowledge, to make sure we don't lose our knowledge. And I'd say like, in our region, I'm a behavioral health provider, both the substance use disorder, licensed addiction counselor, and a mental health counselor. And the way we kept our organization strong, Native American organization strong, is by associations. We worked in groups. And the other thing is that we also worked with the feds quite a bit, SAMHSA in particular, that they were always helpful through the Montana West, I think it's Mountain West Addiction Technology Transfer Centers. I think they changed their name now. But to me, that was taking that research and, how you apply it at the local level. So to me, that's going to be critical too, is how you take this knowledge and how, that best practices around Native American country, and how do you implement it at the local level. So that's going to be important. And I guess the other thing, I think this is how this is going to save the government money, and it's going to have a great impact in Native American communities, is I could see that traditional medicine, how we view the world may be different than the Western world. And I say that because right when I'm sitting here, I get an email from a family member saying, "Lenore, can you help me? My sister's ready to take back her kids. If from the Western world, I probably wouldn't be able to give her back her kids because she didn't complete treatment. She didn't follow all the steps that we wanted her to do, but she's ready now. So instead of going through the systems that keep these kids away from them, how do we do that healing part? So I'm hoping that traditional medicine will also help us with the social services world and how we view that. So I guess, again, thank you for all the hard work you did.
Absolutely, thank you.
So I just wanted to say thank you. I'm just so excited to hear about the things you're doing, and I would like to come and visit and really spend time to find out more. So thank you.
Absolutely, anybody are welcome. We like to host visitors, for sure.
I have one more question. In our community, one of the major areas that we're really having a low impact on is pregnant women with children, and they're not being identified, and we're not doing a good job. So do you see any ways that traditional medicine can help with that?
Yeah, I'm sitting here looking at my pal over here, Elena Eagleshield. I think she's going to talk a little bit about this, but we are addressing that both in an outpatient way and also an inpatient way. So the other thing is we are going to be reopening our residential treatment program. We're moving from 65-bed residential treatment program to 92 beds. Scheduled to open in September of next year, with 15 beds dedicated specifically to serve pregnant and parenting people. Because we do recognize that we're losing generations, to addiction, and we want to make sure that we can address that in an inpatient setting. Now, that said, I'll have to tell you that that inpatient setting, that residential treatment program, was really a foundation for the Seattle Indian Health Board and how we actually conducted our traditional medicine work. I feel like the more recent movement has been towards more an outpatient, right? If you think about, there's like nice synergy between behavioral health and traditional Indian medicine. It's when we add the kind of that Western medicine where sometimes there are these like historic hierarchies that exist that we had to dismantle, in order to implement this model. So yes, I hear you. And we were recipients of the HRSA Innovations Grant, and it's about returning our birthing sovereignty communities. And Dr. Elena Eagleshield is one of the folks who helps us advise on that and is helping us implement that full program. So yes, I agree with you. And I think that the answers are in our cultural knowledge, our cultural ways of being. Other questions? People hungry? Is that what's happening? Okay. Well, if we don't have any other questions or discussion, I just want to tell you it's a real honor to work with all of you, and I want to thank you. As a person who's third generation of my family to live in an urban area, largely growing up culturally disconnected. I have a personal passion for bringing this to fruition. I have a good understanding of Western systems. And I have a responsibility to that that blood memory, right, that I crave so much. And so we will continue to do the very best we can to get these different ways of thinking to kind of move together, because we know ultimately it's better for our people. So I just want to say thank you for having us.
Thank you so much to the Seattle Indian Health Board for Esther, Andrew, Layla, sharing your information and your knowledge, being so generous with your best practices and your resources. We certainly appreciate the work that you guys are doing, and love that we are shifting away from this deficit model to using our strengths and an asset-based model. I agree. Culture is a protective factor, and traditional healing is part of this. And thank you so much for just allowing us to showcase the incredible work that you guys are doing. As mentioned by Esther, that was the last panel before lunch. So it's now time for lunch. So for just a couple of housekeeping for all of you, if you have ordered food, you can pick the food up. I believe it's coming. It's going to be placed right over here at these tables, or actually it's outside, right outside of this enclosed space, but to the right of the table. Elise is pointing to where you can find it. She's in the back of the room, and she can help direct you. If you didn't order food, you can take the elevators. There's a cafeteria on the penthouse level, which is our 8th floor. The button will say PH, so just push that and you can go to the cafeteria. And you can also exit the building to get food, but you must have your ID to be able to get back into the building. So if you leave, please make sure you take your ID. We're asking for everyone to be back in your seats by 12:25 for our special keynote presentation from the Substance Abuse and Mental Health Services Administration. So thank you all for such a great morning, a great conversation and discussion. Carry them on through lunch, and we'll see you back at 12:25.
Produced by the U.S. Department of Health and Human Services.